Hello, I am Dr. Britt Campbell from Virginia Beach. I'm with the OrthoVirginia East region, and we are here to talk today about the ACL tear and some finer points about how to take care of the ACL, including surgery. So let me introduce a little bit about the ACL. The ACL is the central pivot mechanism of the knee. Here's a model of the knee. We take down the kneecap, we look inside the knee, and you see this band of tissue in the middle here. This is your ACL. It's called the anterior, which is toward the front, cruciate because it crosses another ligament, the ACL. It's responsible for restricting and keeping the knee stable in terms of a anterior push as well as a rotational push. You can see as the knee moves, as the lower bone, the tibia internally rotates, the ligament goes under tension. So it's got a rotational stability component as well. So when somebody hurts their ACL, there's usually that mechanism. In other words, it's either a hyperextension where the knee goes into fully straight or beyond straight, and there's a rotation at the same time. When that happens, the tibia goes forward, the ACL comes under tension, and then it fails. And what also happens is that, as you can see here, the condyle of the lateral femur, the outside of the knee, bangs into the back of the tibia bone, and you get a classic bone bruise that occurs almost every single time when you tear your ACL for the first time. In addition, when the ACL ruptures, there's blood vessels in the ACL, and they tend to bleed. So the combination of those additional injuries, besides the ACL failing, is you get a very swollen knee and you get a very painful and stiff knee because of the associated injuries. So that brings us to what happens after you tear your ACL. The classic injury for the ACL is you're on a field or in a court, and you're playing a sport that requires stopping, starting, or cutting. Your ACL, your knee wobbles, you land awkwardly, coming down from a jump or get knocked off your feet, and you come down awkwardly on your leg, and you go through that rotational injury where your ACL is put under stretch and it fails. The classic history is a pop is felt. And immediately after that, you get swelling very quickly. And almost always the patient is unable to remain on the field and continue to compete. They're taken off the field, examined. A lot of times there's spasm in the leg, so it's difficult to know exactly what's injured. But the history kind of gives us an information, and the fact that you're unable to put weight on it afterwards and continue to play is a good indication that there's a serious injury to your knee. When you have the associated swelling, that typically after an acute injury is bleeding, and that means some structure has been injured. And the ACL is one of the most common structures to be injured in that scenario. So that leads us into what happens after that initial evaluation or treatment. You go through icing. Typically there's bracing to protect the knee, and crutches are involved because you're typically not able to put a lot of weight on the leg. Now, if you happen to be in a ski area when this happens, it's a good idea to get braced up, get taken care of, get your knee calmed down, but you will almost invariably want to come home before you have any surgery done, because the knee is not ready for surgery in the first couple days after the injury. There's a great deal of recovery the knee has to go through before you want to start the surgery or think about the surgery. So we'll come back to that in a minute, but I want to talk a little bit about a recent article that was in the American Journal of Sports Medicine. This is a lead article for the March issue a month ago, and it reviewed a number of ACL injuries that were recorded in Sweden. Sweden is a national health country, and so they have registries for a lot of injuries. ACL is one of them, and they recorded almost every ACL in the country that was injured for 3 years. That was about close to 22,000 ACL injuries. And so what these authors did is they reviewed when people had their surgery. Did they have it right away, within a year after the surgery, or sorry, a year after the injury? Did they never have the injury or the surgery, or did they start not having the surgery and then decided to change their minds and go back and have the surgery? And how did those different groups of people turn out? And in terms of how happy were they with their knee? So they look at the registry tells when they had the injury, and tells, and it reviews when they had follow-up in terms of how well they did. So it turns out when you review the information 5 and 10 years later, the people who had their ACL done early had better knee scores and better satisfaction with their knees than the people who tried not to have surgery, but then ended up having surgery a year or more later. And the people that there was a small subset of people that didn't have any surgery. So the numbers stack up like this: 20,000 people were the people that had their surgeries early on. 1,000 people didn't have their surgery early on, but decided to have their surgery later on. And 500 people total out of 3 years in Sweden decided not to have surgery at all. So the vast majority of people went on to have surgery early on. And the reason for that is, and that was not uncovered in the study, but the reason we think that is people tend to feel better a few months after their ACL tear. They return back to their sport, or particularly if they're a young person, their knee feels good, the swelling's down, the bone bruise is gone, and they say, hey, I feel pretty good. I think I'll go play some basketball with my friends. And then they twist or land awkwardly again, and that knee goes out again. Now the ACL's not there. There's other structures that kind of hold it stable that are secondary restraints, but now those are getting injured. So the second time you have your injury, you cause additional injury to your knee, possibly meniscus tear, possibly cartilage damage, possibly something that can't be fixed. And the more that happens, the odds increase for you to end up hurting something that we surgeons can't fix or can't correct completely. So an isolated ACL tear with no meniscus damage is a better knee when it's done with surgery than a knee that has ACL tear and meniscus damage and cartilage damage. And that second knee is not going to be as good for playing sports, or potentially even doing lesser activities as you get older. So let's go back to the what happens after the injury. So you've got your brace on, you've got your knee packed, you're taking an anti-inflammatory or Tylenol, whatever mild pain reliever you need, and then you see your local orthopedic surgeon. At that point, we evaluate you, we examine you, we get an X-ray to make sure there's no fractures involved, because if there's swelling in the knee immediately after the injury, that can be a chip of bone, or worse, a piece of bone gets knocked off, and we want to know about that. So we start assessing you right away for what your needs are going to be after the injury. Not every single person that has ACL tear needs surgery. The majority of young people will get surgery and need surgery. But as you get older, when you're not as dependent on your knee for sports and you have other considerations in your life, like taking care of your kids or getting to work, then the need for surgery becomes less. Now, we still do surgery way into people's middle years because they need it. I've had patients where they're not an athlete. For instance, I had a patient that hurt herself at the beach. She got knocked over by a wave, tore her ACL. She didn't play sports, but 3 months later, she was having trouble vacuuming. So she turned around the corners and pivoted with her vacuum, the knee would give out. So that's a person that's not a sports person, but somebody that still needs surgery to stabilize the knee and protect it from future injury. And she was very happy after having had her knee reconstructed. But typically the young person who's going to be, basically feels they're bulletproof is going to say, oh, okay, that was just a bad time. And they've forgotten about it, how swollen and painful it was. And the knee is moving fine now. So they feel like it's okay. You go back on the court, you cause additional injury. We don't want that. And that's why I think the people that waited on their ACL surgery in Sweden had a worse result than the people who had it early on. So typically you go to see your doctor, you'll have a brace and crutches, and you'll start careful rehabilitation, trying to get your motion to come back. You want the knee to calm down. You want to see how it feels. As you get older and there's other considerations like work and kids, we typically will wait a little bit longer on doing surgery than a person who is young and is just trying to get back to a sport, or trying to get to the summer when they can work and earn money for college, et cetera, et cetera. The person who is older may go through rehabilitation. We may try bracing, may see how they do, but we almost always get an MRI as part of the evaluation. The MRI does a couple of things. It tells us, it confirms the ACL is torn. Usually we can confirm that pretty well with our clinical examination in the office. It's not always easy to do a clinical examination on the field because the muscles are tight, the adrenaline's flowing, and the person's not able to relax a lot of times because there's immediate pain. But in the office, a couple of days later, we're able usually to tell pretty reliably how the ACL is. We always get confirmation with the MRI, but the MRI is usually done to determine what the associated injuries are, meniscus damage, cartilage damage, that kind of thing, because that will have a great effect on the urgency for surgery. For instance, if we see that the person has come to the office and they can't quite straighten their knee out, we get the MRI and we see a meniscus is torn and that meniscus is displaced and not where it should be. It's in the way of the knee. That will have a huge impact on how quickly we want to do surgery, because sitting back and doing rehabilitation, waiting for a few weeks is probably not going to happen for that person with a displaced meniscus than it would be for somebody who has no meniscus damage. We can take our time a little bit and let the knee calm down a little bit more. For someone who has a displaced meniscus, your knee probably won't go straight all the way because the meniscus is blocking that motion, mechanically keeping you from straightening your knee. And it's not going to get better by waiting. It's not going to get better by doing more rehab. And so in that situation, we have to go in there earlier and maybe not wait for the knee to be perfectly ready for surgery in order to save the meniscus. The earlier you put the meniscus back into position and repair it, the better chances you can save that meniscus and preserve the knee for future life. So you do a little rehabilitation, you do it as tolerated, you don't force it until you see what the results of the MRI are, unless the person has got good motion when they come to see you. So the MRI gives you some more information, and it gives time for the patient and their family to sort of let this sink in. A lot of times for our young athletes, our high school athletes, and our college athletes, this may be the first time they've had a major problem in their lives, a physical problem in their lives. And it can be very devastating. And we do keep Kleenex in the office for that reason, because it's a difficult conversation to have, telling a person that you've got a significant injury and we're going to recommend surgery for you. And here's what we're going to do. We're going to get you through it. But there are often some emotions associated with that. So we start assessing you almost immediately in terms of what your needs are going to be. What kind of sports do you play? Do you work out in the gym only, or do you play women's soccer on the weekends? Are you a college athlete? Are you a high school athlete that wants to be a college athlete? So all these considerations are factored into timing of surgery and rehabilitation, and then eventually graft choice and what we do. Again, we know that by operating after first few weeks when the patient is feeling better, but before 6 months or years goes by, that we can get you a better knee than if we wait over a year to do the surgery. And so we do encourage that as soon as you can to get your knee taken care of. And that doesn't mean you miss finals to do your knee surgery, but maybe you try and get through the finals and then you do your surgery right after the finals. So we work with people on that. And one of the things that starts coming up early on is how easy it is for a person to get their motion back. I make decisions for that patient based on how easy it is to get your motion back, based on your overall body laxity, based on your activities, based on your future goals for your knee. And so we factor all that into play when we decide, timing of surgery, what the graft choices are, and that kind of thing. So for instance, occasionally we'll see a patient that takes not the usual 3 weeks to get their motion back after surgery, but can take 2 months to get their knee back after surgery. And so when somebody is working hard and going to physical therapy, and they still have the instability, but they can't move their knee very well, that becomes a different choice for someone in terms of their graft and their timing of surgery. So that person, the person that we're waiting on to get their motion back, we're going to delay their surgery, making sure there's no meniscus displacement or something like that would change our plan. But we're going to delay that surgery until you get all your motion back, because that same person is going to have a lot of trouble getting their motion back after the surgery. So for the person who's slow to get their motion back, we hold off on the surgery a little bit longer, and that also may influence our graft choice. So let's talk about graft choice a little bit. This is a very personal decision for a lot of surgeons. We've all had our own experiences going through our training and seeing how people do after different grafts, and so we have our own biases. But suffice to say that if your surgeon is comfortable with the graft he recommends to you, then that may be a good indication that you should take his recommendation, because he can make that graft work in his hands. I think there's some, pros and cons, and everybody has their own feeling about how the different grafts turn out. But when you look at the literature, most of the grafts end up being about the same, except with one exception, and that is cadaver tissue. So cadaver tissue, we refer to it as allograft. Allograft tissue comes from an outside source from your body. Autograft is the grafts we typically recommend for folks getting their ACL done, because it's your own tissue, and that tissue heals in a little bit better into your own knee than if we take somebody else's tissue and we bring it into your knee and expect it to heal in there. Studies have shown that while the cadaver tissue is a little bit less stress on the person at the time of surgery, it takes longer to heal in place. So the body has to recognize the foreign proteins and deal with them. And fortunately, the knee is immunoprotected. So you can do that kind of thing. You can bring in outside grafts without doing a liver or kidney type testing ahead of time and doing, donor matching and that kind of thing. So you can bring in tissue, but there's still a warm-up time for the body to get used to the new proteins. They have to kind of substitute those proteins out and break those down and bring in blood vessels and make new proteins that the body makes on its own to make the tissue that you put in there the new ACL. But that all takes time, and it takes longer to do that than when you put in your own tissue. So in those situations, when you take a young person who's been through a major surgery, because even if you do the allograft tissue, it's a major surgery, and they have pain, they have swelling, but they get better relatively quicker than if you have taken the tissue from the patient himself or herself. And that additional trauma, if you will, to the knee takes extra time to recover. Well, during that time, the tissue is healing in place. With the allograft tissue, it's a quicker time to recover from the surgery, but it's a slower time to get the knee to accept the new tissue in place. And so you actually have to protect that person longer, even though they feel better sooner. And so that dichotomy makes it difficult for young people to be patient, because your knee feels good, but you're telling them that their ACL is still healing slowly. And so the failure rate for young people less than 25 and certainly less than 18 for allograft tissue is actually much higher than using your own tissue, whether it's patellar tendon, quad tendon, or hamstring. And so it's almost universally recognized that you should avoid doing cadaver tissue for young people ACL reconstructions. Other than that, if you use the person's own tissue, whether it's hamstring or patellar tendon or quad tendon, there's different pros and cons to each graft. There's no perfect graft. Every graft has its own pros and cons, but the allograft tissue tends to be a problem for young people. Now, as you get older and the patients are more sedate and they go through a slower rehabilitation, they've got other considerations, and they're not rushing back to sports, and they may listen to instruction better, then allograft tissue certainly is an option, and it's not as much of a problem as you get older. Now, my personal bias is I've seen people do very well for decades using the patellar tendon graft. That's a great graft. It's particularly good for people that play court sports or field sports. It's not so good for people that do kneeling sports, like surfing, for instance. Here in Virginia Beach, we have a large surfer population. If I see a surfer that tears their ACL and they're unstable, say they surf a lot, but they play a little bit of soccer, but the surfing is the thing, which is how it goes a lot with our surfer population. They are going to be more disappointed with a patellar tendon graft, because the rate of kneeling pain after a patellar tendon graft is higher than with the other grafts. There still can be kneeling pain, even if you have a hamstring or quad tendon, you still can get kneeling pain, but it's a higher percentage of those patients with the patellar tendon that get that. So we tend to steer those folks away from that graft. The motocross crew also has knee pain because they're constantly in a flex state position. That puts more stress on the patellar tendon. And so hamstring or quad tendon tend to be more of what we recommend. So the reason for that is when we harvest the graft, we take a thin strip of the patellar tendon. And the nice thing about the patellar tendon is you take a little bit of bone with each side. But when you kneel on the kneecap, as you bend your knee and kneel on it after the surgery, there can be discomfort there. And so when I get to know you, or when your surgeon gets to know you, they ferret out that information about what you like to do, what you plan to do in the future, how your knee is going to be treated in the future, and that graft can be chosen specifically for you to give you the best outcome. So scar tissue is a big issue after surgery, especially if you've rushed into surgery. Maybe your meniscus is displaced and you had no choice, but you had to go in early. That range of motion problem can happen afterwards. And so often after surgery in those situations, you may require additional treatment or prolonged rehabilitation to get your motion back. In every case, you have to make sure that mobility around the patella is maximized, and that's something that rehabilitation has done. And when you've taken care of hundreds of athletes over the years, you realize that patellar mobility is important. Even if you don't do a patellar tendon graft, you've got to get that patellar mobility, otherwise they're not going to be comfortable. And some people naturally form scar tissue, and they are people that will have a harder time, but they'll give you a clue because they'll be slow to get their motion back afterwards. So with that being said, and just a brief introduction into the world of graft choicing and customization for each patient, we are now scheduled for some question and answers. So Margaret's going to help me with that. I look forward to answering your questions.
All right, thank you so much, Dr. Campbell. We've had several questions come in already. So somebody says, I'm 67, have right knee pain/stiffness and occasional instability. If I have a tear, either meniscus or ACL, and physical therapy has failed, what are the surgical options? I had it injected and that lasted for a few months, but how often and how many times can I have that done?
So in that scenario, we don't know what's torn exactly. I didn't hear that you had to have an MRI to confirm if there's a meniscus versus a ligament tear. But in this, we'll take the scenario where there would be the most options, which is when you have normal x-rays. So we do standing x-rays on everybody, unless there's obvious injury that would prevent us from doing that. But you have standing x-rays, and that standing x-ray tells us what your arthritis status is. So as people get older, they accumulate wear and tear to the knee, and some people degenerate quickly to arthritis and have arthritis in their 50s, and some people may have no arthritis late in their 60s, as perhaps this person does. So that opens up a lot of options for you. If you have a good knee without arthritis, then we're going to treat you like you're 25. But if you have a bad knee with arthritis, we're going to treat you like you have arthritis, which is a whole different algorithm of treatment options. So for instance, if you have a lot of arthritis, we're probably not necessarily going to get an MRI because we know the meniscus is going to be bad. We know that your pain and swelling is coming from the arthritis, and our focus is treating that pain and swelling from the arthritis rather than the underlying structural pathology in your knee. On the other hand, if you have a normal knee on x-ray, then we're going to be more aggressive with that in terms of getting MRIs, looking for the meniscus damage, looking for ACL damage if you're truly unstable, and we can determine that on examination and by your history. Then if you have a knee that looks like a 40-year-old knee, I'm going to treat you like a 40-year-old person. I'm not going to treat you like a 67-year-old person with arthritis. I'm going to treat you very individually based on how you present and the findings we have. So injections can be done, but we would tend to do injections more for people that have advanced or are on their way to arthritis. But if you have a normal knee and swelling, then we might hold off on the injections and start working up, the tissue damage in your knee that might respond to surgery for a long time rather than just doing an injection that would just be palliative.
Great, thank you. Is it possible for the ACL to reattach itself when there has been a complete tear? And if there is a complete tear and no surgery, what activities will no longer be possible?
So the first question is, does the ACL heal itself? Well, in general, we never say never, but in general, the ACL, as you can see here, is in the middle of the knee. There's no soft tissue support. It's strung in the middle of the knee, as opposed to the PCL and the other ligaments, which are surrounded by soft tissue. So the other main three ligaments of the knee have healing potential. The ACL has almost no healing potential because once it's completely ruptured, the blood supply is now severed, and there's no way for nutrition and healing elements to get to the knee anymore. And so it can scar down, it can heal, but it typically will not heal in a functional position again. A lot of times we'll see, or not a lot of times, but occasionally we'll see an ACL that's torn off a part of the knee and actually seals and heals itself to the PCL. And so when the MRI comes on, the MRI is somewhat equivocal because the reading of the radiologist is that there's ACL tissue. It looks like it's about the right position, but it's not attached. And so you have to be very careful with your clinical examination and your history about what's going on there, because the MRI can lead you to think that maybe the ACL is okay. But in fact, it's almost never okay if it's completely torn. And the reason is because there's no tissue support for that to happen. Now, the second question was, repeat me the second question again.
Sure. With a complete tear and no surgery, what activities will no longer be possible?
So with surgery or without surgery?
Without surgery.
So without surgery, you would classically be limited to surgery to activities that are straight ahead. In other words, you could theoretically run, you could theoretically bike, you could swim, you could work out in the gym. There's a lot of things you could do, but as soon as you start accelerating, twisting and turning, pivoting, moving from side to side, that's when the ACL comes at play, and then your knee would be at risk for further injury and instability episodes. With every instability episode, there's a risk for further injury. With the surgery, all sports are on the table. You can play, as you know, if you read the papers, you're able to turn back to professional sports as well as recreational sports. But without the surgery, you should limit yourself. Now, you may be able to get by with good quad rehabilitation and bracing, and some people can actually do that very well. There was a guy I played volleyball with a number of years ago who swore that he had an ACL tear, and I didn't believe it because he had perfect x-rays. But sure enough, I examined him and his ACL was out, but he was 10 years out from his ACL injury. He had no arthritis, which is classically what happens because the knee keeps giving out. And he was just one of those individuals who was able to cope well and was able to get by and do his sport without surgery. But that's not the rule. That's more the exception.
Thank you. Somebody asks, my ACL broke about 20 years ago while I was skiing, and I didn't have it repaired. I just lived with it and changed my lifestyle. An orthopedic surgeon that I saw mentioned that I will get arthritis sooner in the knee that had the ACL injury. Their question is, can I prevent the arthritis by taking any precautions or by repairing the ACL now?
So the ACL, first of all, yes, you can. There's precautions you can take to protect your ACL. Again, if you're going to participate in sports or activities, maybe it's hiking or even mowing the lawn on a rough surface, putting a brace on using one of the ACL braces that we have available and can get for you will help to keep your knee more stabilized and supported. And you combine that with a good quad and hamstring program to strengthen the muscles in the thigh across the knee, then that would be your optimum prevention as well as some activity modification. If you don't do that, then you are at risk for having increased problems. Now, we do surgery in those situations because the individual, not talking about the Swedish study where the people that crossed over didn't do quite as well as early, because they didn't compare how bad those crossover people were to where they were before they crossed over to after they crossed over. They just looked at the final results. But presumably you're having problems that you would entertain the notion of having ACL surgery. So 20 years later, and we've operated on patients like that, and they keep giving out, and it's disconcerting to do things. Sometimes they'll have their knee will give out mowing the lawn, vacuuming, stepping off a curb. And those are situations where it's very easy to say you would do better with ACL reconstruction because you can't step out of the shower and wear your brace immediately, and you're at risk when you twist in the shower because your knee might give out. So assuming you have an ongoing instability, then you would benefit from the surgery. Now, if you don't have any problems with your knee, if your knee doesn't swell up, if your knee doesn't hurt, if it doesn't give out, and you're able to do the activities you like to do without any problems, then it's not necessarily going to be helped by ACL reconstruction. Now you can get an idea by looking at the MRI and the standing X-rays to see what damage your knee has accumulated over the years and to see if there's actually going to be arthritis in your future. But if you have a normal knee like my volleyball buddy a few years ago, and you're not having any problems and no swelling and no signs of distress with your knee, and you're able to do the things you want to do, I don't think your knee is at risk for arthritis. It's certainly not. It's not going to be diminished in terms of risk for arthritis by having an ACL reconstruction. You've got to have some symptoms for us to make you better.
Thank you. Somebody asks, what exercises would you recommend to strengthen muscles to support the ACL after surgery? I had ACL surgery 20 years ago, but in the last 2 years, my knee has been feeling loose.
Yeah, so it's possible that your ACL may no longer be functional as you've now had this objective looseness that you're talking about. The muscle group that's most dynamically responsible for stabilizing the knee and reproducing what the ACL does is the hamstring group. So you'd like to have strength in your quads because that helps you run and stabilize your knee in the front of the knee, but you also want to have dynamic stabilization for your hamstrings. And you've got to have a balance, but oftentimes people go to the gym and they build the quads up. They can see the quad contracting and it feels good to strengthen it. But the hamstring is at least as important as the quads. And so you've got to do hamstring curls, hamstring, plank exercises, hip exercises to build up the entire posterior aspect, the back aspect of your hip, thigh, and knee to stabilize. And that will help stabilize when you're having absent ACL or a loose ACL in that case. For someone who's feeling looseness, it may be reasonable to look into bracing as well. Talk to a surgeon about the pros and cons of getting late surgery versus what your knee is all about right now. But to start with, it's a very good idea to rehab and reintroduce to yourself the quad, but especially the hamstring strengthening exercises.
Thank you. And one last question for today. If we don't get to your questions during this talk, we will answer them in the comments later. So our final question is, why are young women athletes more prone to ACL injuries?
Well, that is a huge question that's become even bigger with Title IX, because when all the sports teams started for women, there was more women athletes going out in the field and having injuries. And so the numbers come down to that women are, especially teenage women versus teenage guys, are 2 to 7 times more likely to tear their ACLs than the guys. So the reason that is probably multifactorial, and there's new reasons being explored every year. But one of the biggest reasons is that women, when they mature physically, they have wider hips. Their knees tend to be a little bit more knock-kneed or valgus. There's a little bit of a thought there could be some laxity in their tissues more than the guys, and so combination of muscle factors and bone shape factors and even hormonal factors contribute to making your knee more likely to go into an interrotated valgus extended position, which is the exact position that your knee is at risk for tearing their ACL. So in fact, this is something that OrthoVirginia is working on right now across the state, is ACL prevention. And the ACL prevention, there's a couple different ACL prevention programs out there. We're going to pilot both of them. But the main push on those prevention programs is to get people, women and guys, to land with their knee a little bit bow-legged, a little bit flexed, and a little bit external rotated. exactly the opposite of the way you would tear your ACL. So it's physiological training of your knee to help you land and come down from a height better in a more correct position to help protect your ACL when the body is under the most stress. That is landing off of a jump or coming from a awkward run or a bump when you're chasing a soccer ball. So there's a lot of factors, and they haven't all been worked out, but those are at least some of the factors, and we think we can maybe influence some of those factors with these training programs, and we're hoping to bring these training programs to all the regions across the state of Virginia, hopefully soon.
All right. Again, thank you so much, Dr. Campbell. Would you like to close?
Yes. So thank you very much for listening to me. Hopefully this has been helpful, and I've piqued your interest and maybe even more questions. Again, I think it's important that, especially for young people, that with the ACL tear, that you do seek out a physician or a surgeon who's had experience, because that surgeon with a lot of experience is going to be able to work with you to find out the exact best treatment for you in terms of taking care of your meniscus injuries, the ACL graft choice, the timing of the surgery. And that is something that experience teaches us, and we learn from our experience, and that's how we become better surgeons, and we can help you better with our experience.
Please visit us online at orthovirginia.com for additional information. Thank you.